Hi, everyone. Thanks for joining us this afternoon for the last stretch of the TD Cowen Novel Mechanisms in Neuropsychiatry and Epilepsy Conference. This is the MindMed Fireside Chat. I am TD Cowen Senior Analyst Ritu Baral. I'm joined by my colleague Athena Chin, who works with me on our Team Baral Neuropsych names, and the CEO of MindMed, Rob Barrow. Rob, thank you for joining us today. Really looking forward to going through your story and next steps. Obviously, the talk of the last year around MindMed has been around MM120 and your phase 2 data that was recently published in JAMA, but top line last year. Maybe we could start with the mechanism of that drug, which is LSD, that drug in generalized anxiety disorder, which is the first indication that you're going after. Why GAD over TRD? Is that mechanism related? And then we're going to hit the market.
Yeah, first of all, thanks so much for having me and having MindMed as part of this. We're excited to be here. It's MM120. LSD was really is the most studied and the most prominent historically, most prominent psychedelic. I think everyone knows it by name. It's part of the reason why it really didn't take center stage when the resurgence in research started about a decade ago. Mechanistically, it is a serotonin agonist, a 2A agonist. We know that it has similar activity as some of the other drugs in the category on the default mode network, on really probably working at a different level than just symptom suppression. And so when we talk about indication selection in GAD versus MDD or TRD, we don't think it's selective for one indication over the other. And mechanistically, what seems to be happening with the psychological processing, which again is described by the network effects and turning off the default mode network, it sort of depends on whether you use the lexicon of neuroscience or psychiatry or psychotherapy. But it seems to sort of reorient psychologically patients' relationship to the inputs from the external world, from internal narratives that are driving these sort of what have historically been called neurotic illnesses such as anxiety and depression. And so mechanistically, there's sort of broad activity, of course, at the receptor level, again, 2A agonists that drive these network effects and dramatically changes both internal and external perception for a period of time, with a resulting opening of the critical learning period, a sort of reorientation of patient psychological processing that seems to drive that longer term durable clinical effect.
And as we think about the GAD market in the US, can you walk us through sort of what the treatment paradigm is right now, what the unmet need remains?
So when we think of anxiety, and back to the first question you asked too, anxiety has been an area that has been so severely overlooked. The last approval in GAD was Cymbalta in 2007. It was a label expansion beyond initial approval in depression. But historically, the focus of psychiatry has been on anxiety symptoms. Really, it was only the introduction of SRIs that shifted the focus over towards MDD and depressive symptoms. So over that period of time, since 2007, the most recent estimate we have for the prevalence of GAD in the US is 10% of the US adult population. It'd be 26 million people. And a lot of folks with GAD, even those who are diagnosed and actively treated, stop treatment. So we have really two classes of drugs that are predominantly used, SRIs and benzodiazepines, which are no longer used chronically because of abuse and safety concerns.
Yeah.
Right. And so we're left with less than a handful of approved SRIs and generalized anxiety disorder. The treatment.
And what is the effect size for the SSRIs in GAD?
Typical effect sizes are less than 0.4. When we talk about Cohen's d, 0.36, 0.38 for both benzodiazepines and for SRIs. So these are sort of mild treatment effects. They're not particularly effective, and they have a pretty high AE burden, sexual dysfunction, weight gain, and just overall general sort of suppression of feeling, which is of course the goal of SRIs, is to sort of blunt blunt the bad feelings, whether they be anxious feelings or depressive feelings, and as a result, try to improve the relative positioning. But really, with the available therapies today, we just don't see a sort of long-term change in trajectory for folks who are living with GAD or MDD.
Got it. So let's go through your data, the phase 2b GAD study. Can you talk to the effect size seen, but also the rationale for selecting that 100 microgram dose?
Yeah, so our phase 2 study was designed really to be a phase 3 study, but no one had looked at, and still to this day, we haven't seen any other studies look at a comprehensive exploration of dose response. But we wanted to establish on clinical outcomes across a full sort of dynamic range of doses what the optimal dose is on a set of clinical symptoms, not just on the magnitude of perceptual effects. Mm-hmm. And that's why we designed a 5-arm study, including placebo and 4 active arms of the drug. And the primary analysis in that study, and this is reported in the JAMA paper, was a dose response methodology. So we pre-specified dose response curves and then statistically fitted to those curves to both establish whether there is a dose response and to come away with a recommended dose to take forward. And that's how we ultimately arrived at the 100 microgram dose. Of course, it helps when the observed data also very clearly suggested the 100 microgram dose was the best one to take forward, because we had maxed out clinical efficacy. We didn't see any increase in efficacy as we increased the dose beyond 100. But we did see a higher AE burden, a longer time in the clinic on the day of dosing. So really sort of optimally balancing both the efficacy and the safety and tolerability.
So Rob, as I have discussions with clients about MindMed, and in fact, in our KOL dinner last night, the focus around LSD was essentially around that treatment burden and the AE profile and the treatment window. Before we get into some of the other efficacy analysis aspects, the great remission rates, response, durability, et cetera, can you talk to that side effect profile seen, the most common AEs, time to resolution, et cetera?
Absolutely. So when we think of the AE incidents that happened, almost, not all of them, of course, but the vast majority were limited to the day of dosing with any sort of incidents. And these were the characteristic effects of taking LSD or a psychedelic. Illusion, perceptual alterations, whatever specific form they took and however they were specifically coded, effectively a change in perception. And this comes up as illusions, hallucinations, pseudo hallucinations, things of this nature. In phase 2, we were using a capsule formulation. There was a pretty heavy GI burden.
Pseudo hallucination?
So when we think about the category of things that sort of perceptual alteration, there's really sort of 3 different levels. So these are talked about as hallucinogens and hallucinations. It's not really an appropriate characterization of what happens when someone takes a psychedelic. So a hallucination means that there's a de novo synthesis of something without a sensory input. There is no radio in the room, but someone believes there is a voice speaking and they believe it to be real. On the other end of that spectrum is an illusion, which is looking at a picture and it, taking a different form of some way, looking at a wall and the wall becoming a fractal or starting to spin or spiral or something. That would be an illusion. And a pseudo hallucination is sort of in the middle where there isn't a sensory input. So there's but a patient is able to determine that it isn't in fact real. And so really what we see is more illusions than hallucinations. But again, it kind of goes to a need for a high degree of focus on how those AEs are coded and observed and recorded.
Exactly. Like it seems like the sort of thing that FDA would scrutinize closely because of the potential safety ramifications, which are certainly lower for illusions and higher for de novo hallucinations.
Typically, we see all these pulled together. So when you look at, for instance, Spravato's label, all of those adverse events are captured as dissociation.
Yeah.
Whether they be illusion, hallucination, or actually coded as dissociation. So certainly when you have a lot of overlapping adverse events, they typically get pulled when it comes down to labeling.
Got it. Any severe AEs of note? What was the sort of patient experience and time course over the trial?
So patient experience was remarkably benign. I think we, of course, everyone has heard this sort of out in the real world stories of illicit use of psychedelics and these difficult experiences, this bad outcomes in some patients, and certainly those things happen out in the world with illicit drug use of any class. So we were prepared for extensive interventions and for needing. Right. For having folks with difficult experiences. We really didn't see much of that, particularly at the 100 microgram dose. Again, I think as we get to higher doses, that experience can become more disorienting. But when we look at our go-forward dose of 100 micrograms, a pretty reliable, predictable experience. There's certainly these are anxious patients to begin with, and so there's some sort of transient anxiety, just kind of as part of a clinical trial, anticipatory anxiety around what's going to happen when I take the drug when I'm in this room. But all of that mild, moderate, and transient, and really it was again a fairly benign profile. Definite perceptual alterations. There was a degree of again a bit of a GI burden with the capsule formulation that we're seeing reduced. So there was some nausea at higher doses, vomiting.
Is that serotonergic or was that formulation induced?
We can't attribute it to one or the other, but we certainly are seeing less of a GI burden with the ODT formulation that we're taking forward in phase 3 and in our ClinPharm studies. So, but again, a remarkably benign profile. I think the thing you mentioned is the time course, and I think there is a bit of a misunderstanding. We have taken a very specific and data-driven approach to how we try to document everything about the profile of the drug. And of course, the time course of perception alteration is a big factor with all of these drugs. In phase 2, we had a extraordinarily conservative set of criteria for how we assess when a patient was clear to leave. And so we basically modeled around any perceptual alteration at all. Hallucinogen intoxication, the DSM is sort of the model we used. And as we gathered those data in phase 2, we both didn't see any sort of physiological burden that would suggest there's a need to monitor or release on blood pressure or heart rates like we see with some other products on the market. But we also saw that we think a more real world like monitoring criteria and release criteria are appropriate. And so as we've gone forward into phase 3, and in our ClinPharm studies, we're using a more, again, sort of REMS-like, real-world-like set of criteria for how to release patients. And that has not only allowed us, as we go forward in phase 3, based on the data we generated, to shorten the required monitoring time from 12 hours in phase 2 to 8 hours in phase 3. But we start monitoring for readiness to leave at hour 5, and we're seeing a lot of patients, particularly in completed clinical pharmacology studies that are ready, meeting that criteria, ready to go as early as hour 5, as early as we're measuring it. And so again, that is more reflective of something we see like with the release criteria for Spravato, or if you think about a PACU, as post-anesthetic release criteria.
So Rob, when a patient, is there consistency to a patient's release time?
Within a reasonably narrow range.
Intra-patient, like as patients get retreated, could a practice say, I see patient X, they will have a release time of 6 hours, because certainly it would go towards predictability of practice logistics.
That's exactly right. That is typically what we see, is that on a given patient, it's not widely variable for an individual patient. Again, that consistency, I think, is even further enhanced with the ODT formulation. And you're getting to a really important aspect here, which is when we think about, I think at face value, there's been this temptation to say, we want drugs that replicate exactly this Spravato model. And that keeps getting referred to as this sort of reference point model out in the world. And
with
certainly that has a
3.5 hour window and whatnot. Yeah.
Yeah, 2 hour
window.
observation. When we think about practice economics and practice operations, the predictability, the reliability of being able to bring a patient in, have them there for a work day, and then let them go at the end of the day, when the monitoring time is reimbursed on an hourly basis, leads to less requirements for room turnover, for patient turnover to get the
Mhm.
same source of revenue. And so when
Mhm.
we look at those logistics, it sort of turns the assumptions on its head. But the kind of monitoring window, let's say it's 6 to 8 hours
Yeah.
ultimately. Obviously, we have to prove this out in
And that's
phase 3
still a normal
studies.
business day. That's not, where that's not requiring overtime from practice employees.
No, in
It's 8
healthcare,
hours.
it's typically you have either 8 or 10 hour days.
Mhm.
So anything around 8 hours would sort of optimally fit into a work day. You're
Mhm.
filling up a bed for the day. There's not wasted time on the end where in healthcare, time
Mhm.
without a patient is
Yeah.
not reimbursed time. And so when we look at the practice operations, practice economics, this dynamic and what we're observing so far in our studies really supports what we think is a pretty attractive opportunity for these sites. And that's also reflected in the data that we see out of Spravato. When we go look out in the world, there's a high concentration of Spravato prescribing and administration, right? It's only a small number of the REMS certified centers that are actually driving Spravato scripts and volume. And so
Mhm.
that the remainder of that infrastructure isn't dosing 5, 10, 20 patients a day.
Yeah.
Those sites are the ones that are, I think, well equipped for a lower throughput model with
Yeah.
better
Yeah.
economics and lower turnover
They're the ones
requirements.
who don't have the Spravato scheduler. So many of these community sites have one person dedicated to scheduling all the in and out ketamine patients. Um,
Right. And we just don't think that model applies to this entire
yeah.
category, right? Whether it be our drug or others, we think there's certainly a different approach that's needed and that we feel really
Mhm.
comfortable with the dynamics of our product.
So let's go back to your efficacy for a second. Can you review for us the key points about the additional analysis you've generated, response and remission at week 12, and then durability that you have, durability data that you have in hand?
Yeah, so some really important findings from the phase 2 study. We saw that at 12 weeks, we had a 7.7 unit improvement in the 100 microgram arm over placebo.
Hmm.
That is around more than double what we typically see from approved drugs. Right? So an effect size that is more than double the standard of care. And notably, that was over an abnormally large placebo. So it had almost 15%, or excuse me, 15-point improvement in the placebo group. So to have that large of an improvement over a large placebo does two great things for us. One, it we think is exciting, impressive efficacy, but it also establishes the robustness of that efficacy because we're not comparing to a nocebo effect or sort of paltry placebo response. We're really saying we've not only exceeded a placebo, but a very large placebo. And
Yeah.
as we go forward into the pivotal studies, assuming the placebo were to return back to a more historical standard improvement of like
Hmm.
9 or 10 points,
Yeah.
it potentially gives us even wider margin to work with when we think about phase 3 outcomes. In terms of other secondaries, 48% remission rate in the 100 microgram arm
Hmm.
at week 12. So this is 12 weeks after a single administration with no concurrent therapy or no therapy that came thereafter, and about a 2/3, 65% uh, response rate at
Yeah.
12 weeks. So we're seeing at least 12 weeks of durability. We didn't see any sort of regression back to baseline or loss of activity over that period of time. We
Are you
didn't
continuing to follow these patients?
Unfortunately, no. And of
Oh,
course,
okay.
it would be great if we had 2 year data on these patients. But based on the nature of that study, we didn't. We stopped
Mhm.
observing at week 12. In the phase 3, we continue to observe patients for an additional 9 months. And so we'll be able to look at that durability well beyond the 12-week primary endpoint.
Got it. So what are your thoughts right now around the phase 3 program? And have you had all of your FDA discussions around that, what the final Voyage and Panorama design details will be?
Yeah, so based on the phase 2 data, we were able to obtain a breakthrough therapy designation, which
Very quickly.
obviously
Yeah.
very quickly, which of course also gave us great opportunity to. I've had the good fortune of working with multiple of these programs under the breakthrough program with FDA, and um, there's an extraordinary degree of engagement we've seen with FDA, not only um, for us just based on the nature of the program, but under the breakthrough programs especially. Um, Based on that, when we had an end of phase 2 meeting last year for our GAD development program, extensive back and forth and great conversation and alignment with the agency, even beyond that end of phase 2 meeting. And we continue to stay closely engaged with the division as we progress with the study. So we feel very comfortable about the design of our phase 3 program, both for GAD and for MDD.
Well, let's talk about MDD for a second. There were signals within your GAD study that informed your decision to start that 120 study in MDD. Can you walk us through those signals and your that trial as well?
Fundamentally, there's a pretty dramatic overlap between these indications. So something like a 60 to 80% construct overlap, and certainly a similar diagnostic overlap between anxiety and depression. Anxiety often precedes a major depressive episode. And so while we of course didn't enroll patients in the phase 2 who were in a major depressive episode, there is intrinsically going to be some degree of depressive symptomatology in GAD patients. The scales are just set up that way. The MADRS and the HAM-A are significantly overlapping. And so we started with something of a lower baseline than you would expect from an MDD dedicated study, right? Patients in a major depressive episode, we expect to have a little bit higher MADRS scores than we saw, but we still saw a dramatic and statistically significant decrease in the MADRS 12 weeks after MM120. And really, again, we almost seem to have bottomed out the scale because we were starting from a bit of a lower point. We had almost 2/3 of patients who were in, well, we don't talk about remission because they weren't in a depressive episode, who would have met criteria for remission. And that gave us a high degree of comfort to expand the program and pursue an MDD indication in parallel to the GAD program. And I think it's worth noting that this kind of fits a larger approach, which is you asked about GAD versus TRD or some other indication. Now, our goal is to have a label that allows us to try to access patients and give them access to the drug as broadly as possible. There's of course going to be other barriers in place, prior authorizations, but to have a label for the two largest psychiatric indications in GAD and MDD, if we're successful in that, it gives us the largest possible market opportunity and the ability, ideally for a patient who walks in the door, to be most easily directed to MM120 over other available options.
Got it. An inbound question from a client. As we have noted, you've mentioned the phase 2b was functionally unblinded. Why was there still such a large placebo effect? And why include placebo in Panorama and Voyage?
So to sort of three points in there. For all of the active dose arms in the phase 2, 88% in the 25 microgram group, 90% in the 50 microgram group, and 100% in the 100 and 200 microgram groups of patients correctly guessed that they were on drug.
Yeah.
Everyone was functionally unblinded.
Yeah.
Only the 2 high doses had a clinical response. So it's a pretty strong argument to suggest that functional unblinding can't explain the clinical efficacy in the first place. The presence of those lower doses, though, 25 and 50 micrograms. So when we think about functional unblinding and controls in any capacity, they have a potential effect on not only the placebo group, but also on the active group. In our phase 2, a third of patients who received placebo guessed that they were getting drug. That's probably more likely to happen when you have a low dose control than when you're saying in a head-to-head study, say 100 micrograms versus placebo. That in part explained, we think, a large placebo response. We
Uh-huh.
also know that just in any clinical trial, the higher likelihood that a patient is allocated to some dose of drug, the larger the placebo response tends to be. So in our
Yeah,
study, patients had an 80% likelihood of getting drug.
I see. Okay.
The third factor is a sort of in the weeds statistical one, which is that in patients who receive placebo and subsequently drop out of the study, their data from that point forward is imputed as if it is from the remaining placebo patients, or treated as if they're part of that placebo group moving forward. So the patients, because we didn't offer anything beyond that initial randomized dose, the patients who did the worst were the most likely to leave, right? So if you have a placebo patient who most likely to not get better or even get worse, they left the study at a higher rate than anyone. And so that
Mhm.
also numerically is going to likely drag down that placebo response. All of these, which we think will be, could potentially be more favorable in terms of mitigating placebo response in phase 3, because we offer the extension period where patients can get open label drug. We have a lower allocation ratio, and we don't have multiple very low dose controls in the study. To talk about the phase 3s and why include a placebo,
Mhm.
you know, functional unblinding is sort of a spotlight has been shown on it for this category of drugs. But this is and I was talking to a KOL a few weeks ago. This is true. Functional blinding happens with every drug in psychiatry. Let's look at benzodiazepines at, 1 or 2 milligrams of Xanax. It was clearly functionally unblinding. And so the gold standard for all of clinical research has been to compare it against a placebo. Now, in Panorama, we're including the secondary control, right, of a 50 microgram arm. And that's there to basically to say to the patient in the informed consent process, look, if you feel the effects of a drug on dosing day, you can't assume it's a clinically active dose of a
Mhm.
drug. We've actually shown that one of the doses being tested didn't have any clinical improvement over placebo in a prior study. And so if there is a confounding dose to try to sort of functionally blind that, but to compare against anything but a placebo for us sort of departs from a long established gold standard in all of clinical research. And we've been very clear and we think very aligned with FDA uh, around our logic for doing so and the approach in doing that in phase 3.
And then in part B of Panorama and Voyage, you're allowing redosing. Can you talk about the parameters where that's allowed?
Absolutely. So patients enrolling in the study have to have a HAM-A score of 20 or greater.
Mhm.
After week 12, patients who continue the study, if they have a HAM-A of 16 or greater, become eligible for open label treatment with
Mhm.
drugs. So they don't necessarily, in most open label studies, right, a daily drug, an SRI that has an open label extension, patients immediately go on to open label drug and
Mhm.
therefore are unblinded. So this design allows us to do two things. One, it allows us to look at the durability of the initial response in a blinded status well beyond 12 weeks. A patient who takes the randomized dose of drug or placebo and say is in remission for the entire year, we can look at the rate of that and sort of survival curves over that entire year to see how long a single first randomized dose lasts in comparison to a
Mhm.
placebo. The other thing it does, though, is then for all of the patients in the study, regardless of what they're randomized to first, we can look at the characterization of retreatment over the course of the year. Or like real world, like on average, how many doses a year does a patient need? What is the dynamics of retreatment? How often is that needed? What is the interval? Does that interval change over time? All of these very interesting and important questions that could be useful in certainly informing regulatory discussions, but also I think
Mhm.
as importantly informing um, you know clinicians and our med affairs and publication strategy over time.
Athena, do you want to take the last set of questions?
With the last minute that we do have, how do you think this would fit within the real world paradigm? How many monitors do you think this would take? And how quickly do you think these patients would be discharged upon the ending of the treatment?
So I guess for the first question, our approach in development is to make every argument based on data. So we go to great lengths in the trials to document what monitors, we call them dosing session monitors or DSMs, what they do during treatment sessions, so that we have data to articulate, if it turns out that no DSM has had to intervene at any point in time, it's not exactly clear what they're doing in the room. And that's what we hear from past studies. A lot of times we've had investigators say, look, I sat in the corner of the room and caught up on notes or read a book. I didn't do anything during the day. So we want to be data-driven in the decisions. If it turns out that multiple people need to intervene, then that's going to be important data that everyone should be collecting as well. But we feel really confident about that. And so far, we've been really encouraged that, again, that there's no concurrent therapy and there's not a lot of intervening that happens by the dosing session monitors. When we think about monitoring time and release and when patients be ready to go, again, it's a data-driven approach. We'll have a structured, granular assessment on an individual patient basis, and of course to do summary statistics around when we come out of the phase 3 studies to argue or to establish appropriate data-driven conclusions for what appropriate monitoring periods would be. But I guess we so far are really encouraged by what we're seeing with the ODT formulation, and in our clinical pharmacology studies have seen a pretty dramatically shortened period of time before patients are ready to go. And I think it would be predictably under that 8-hour or within that 8-hour kind of workday period.
Understood. Well, thank you so much. We're really looking forward to that phase 3 data, both from GAD and MDD programs. And with that, I will wrap up, and we will be hosting Acadia for our next fireside chat. So I hope to see you there. Thanks, Rob.
Thanks, everyone.